In today's podcast, we'll review the physical exam of the elbow. In part 1, we will review anatomy, inspection, palpation, range of motion, and strength testing, and in part 2, we'll review special tests. As a quick review, the elbow is a hinged joint with 3 articulations. Static constraint is provided by the MUCL and the LUCL, and the ulnar, median, and radial nerves will all be relevant to a clinical exam as they all cross the elbow. We've already gone over the outline for part 1 and part 2, so we'll move on to inspection. On inspection, the resting position of the elbow is an important indicator of underlying acute injury. The position of comfort is from 70 to 80 degrees of flexion and is used to accommodate fluid within the joint capsule and is an indicator of joint effusion. The carrying angle should be evaluated next, and in JOST is quoted as 11 degrees in men and 13 degrees in women, being the normal amount of physiologic valgus. Cubitus valgus means that the carrying angle is increased, and cubitus varus, or gunstock deformity, means that the carrying angle is decreased. Next, you should evaluate for swelling, joint effusion, as with the resting position, or additionally loss of the elbow crease or swelling around the olecranon bursa. Moving on to palpation, palpation is carried out by bony palpation followed by soft tissue palpation. The medial epicondyle is easily palpable at the medial side of the distal end of the humerus. In patients with medial epicondylitis, maximal tenderness occurs about 5 to 10 millimeters distal and anterior to the medial epicondyle, at the origin of the pronator teres and flexor carpi radialis. With the elbow in 50 to 70 degrees of flexion, tenderness in the sulcus, distal to the medial epicondyle, or along the ulnar sublime tubercle may indicate injury to the UCL. Tenderness posterior to the medial epicondyle may indicate ulnar neuritis or an olecranon stress fracture. In patients with lateral epicondylitis, tenderness is most often experienced on the ECRB tendon origin, which is just anterior to the border of the lateral epicondyle. The radial head can also be palpated here, while passively supinating and pronating the forearm. Tenderness here may be an indication of fracture, dislocation, or injury to the annular ligament. The lateral soft spot can be palpated between the olecranon tip, the radial head, and the lateral epicondyle. Pain here may indicate synovitis, a plica, or an OCD of the capitellum. Fullness may indicate effusion or hemarthrosis. Moving on to range of motion, the normal range of motion of the elbow is from full extension or slight hyperextension to 145 degrees of flexion, with 75 degrees of supination to 85 degrees of pronation. Abnormal range of motion involves typically loss of extension, suggesting intra-articular pathology. A soft endpoint may indicate an effusion, while a firm endpoint may indicate an osteophyte or loose body. Crepitus or mechanical symptoms are a signal of cartilage irregularity or potential loose body. Of note, throwing athletes may have an adaptive loss of terminal extension, or they may have pain at the end of their ranges, which would be secondary to chronic valgus stress. When evaluating strength of the elbow joint, it's important to compare with the contralateral side. Inability to extend the elbow actively may represent triceps rupture. Grip strength should also be evaluated if epicondylitis is suspected. If weakness is uncovered on physical exam, it's important to consider cervical nerve root pathology or brachial plexus injury. As such, a thorough neurovascular exam is extremely important to the elbow exam. The dermatomes, myotomes, reflexes, and pulses should all be evaluated. The chart below can be helpful to differentiate the level of injury.